Again, hello everyone. Today we are going to discuss about one of the most clinically important protozoal infections, and it is considered as one of the most top three killer for the world. So let us discuss about malaria. So when you come to the malaria, it is a protozoal infection caused by the vector transmittable by microorganisms called Plasmodium. It is caused by Plasmodium. This has different species. Later on, we'll discuss it by different times or different sectors. So it is vector-borne disease. It is a vector-borne disease. It is vector-borne disease, and it is transmitted by Anopheles mosquito. Anopheles mosquito. Mosquito, and it is transmitted by the female ones. The male Anopheles mosquito usually they don't transmit the microorganisms. Rather, the female one is the one responsible, because the female one is the one which has the instrument to suck blood and which one carried the eggs. So she requires the blood as a nutrition supplement for her eggs. So the female is the one responsible for the transmission of the microorganisms. So in the case of preventive mechanisms, we need to attack the female Anopheles mosquito rather than the male one. So what are the etiologic factors? As I mentioned before, it is because of the microorganisms called Plasmodiums. Currently, there are 5 identified species that can potentially cause a medical disease called malaria. So starting from the word malaria is different from mal and air. So mal means smith, like bad. Air means it's like air, the environment, the air. So previously it was considered that malaria was caused because of the bad air, during in the case of Aristotle's and like that. But I don't know their much detailed history, but the word comes from that. So what are the etiologies? What are the etiologies for the malaria? As I mentioned before, we have 5 identified species. The first and the famous one is a Plasmodium falciparum. Plasmodium falciparum is the severe ones among all of them, and it is an acute one. So it is severe. It is a severe ones. It is the most acute, and it is most common in the sub-Saharan countries. The second one is Plasmodium vivax. It is very known for its relapse, because later on we'll discuss about the life cycles. It has hepatic stage where it can stay for more than a year without causing any inflammatory reactions in the body. So it can hide itself into the hepatocyte. So Plasmodium vivax is also known. The other one is Plasmodium ovale. Plasmodium ovale is also the same as Plasmodium vivax. It is known for what? Its relapse. It's known for its relapse. The fourth one is Plasmodium malaria. This one is malaria, Plasmodium malaria. It is also known for its chronic infection. It's known for chronic infection, and it is one of the most common etiologic agents that could present with renal injury. We will, when we discuss about this glomerulonephritis, we will discuss it in later. But Plasmodium malaria is known for renal injury. What kind of renal injury? We'll discuss it in our nephrology sections. And the other one, and the newly identified species, and it is a zoonotic ones that transmitted from the monkeys. It is a zoonotic one, and it is a new one. It is usually found in the southeastern Asia part, southeast Asia. So it is a zoonotic one. It comes from monkey. It comes from monkey. So this is basically the currently known etiologic agent that can potentially cause malaria. So one of the most studied life cycles, I will put the image here. The most studied life cycle is a life cycle of malaria, because it is clinically very important. It helps us to in the management. It helps us in the preventive mechanism. So we will discuss the malaria life cycles in details. So as I mentioned here, the malaria life cycle is a vector-borne disease. It is a vector-borne disease, means that it is transmitted from the or it uses a malaria Anopheles mosquito for the transmission of this microorganism. So the life cycle take into places. So the life cycle. So the life cycle take into places. So there is a life cycle that takes Anopheles, and there is also the life cycle takes in the human. And inside the human also, it has two places to take. The first it takes inside the liver, and the other one is inside the blood. Inside the place it takes a life cycle. So to make it clear, understand, you can start from anywhere just to understand the pattern, because it has some cyclic pathways. But to make it clear, I will start from the liver one. You will know it now. So let's say there is Anopheles mosquito. This Anopheles mosquito contains Plasmodiums, this Plasmodium's sporozoites. So she has sporozoites. Sporozoite is the one that is infective for human stages. So let's start from the sporozoite. So there is a human being here. So this Anopheles mosquito infects these human beings with this sporozoite. So what will happen is the sporozoite inside the blood, the sporozoite will pass and get into what? The liver. So let's say this is a liver. So sporozoite, and this one is the blood vessel. So there is sporozoites here. So these sporozoites come to the liver. They are not in the hepatocyte still. They come to the liver. So once they come to the this sporozoite come to the liver, they will lose some part of their structures and they will change it into liver trophozoite. And these liver trophozoites entered into what? Inside the hepatocytes. So inside the hepatocyte. Now we are inside the hepatocytes. So they will enter into the hepatocytes. So when they are entering into the hepatocyte, they start to what? Multiply. So they start to multiply. Multiplication. It is a binary fusions, especially only in the nucleus. The nucleus start to manipulate. So there will be a nuclear fusion. For example, if this one is a hepatocyte and if this is a sporozoite that entered into, then by the nuclear fusions there will be this is hepatocyte again. So this is the plasma membrane. So there are so many nucleus inside the cells. If you can access to take the samples from the malaria infected individuals, you will see such kind of structure. So it start to multiply. When it start to multiply with nuclear fusions, this liver trophozoite is called now what? Schizoid. It is called schizoid. So it will proceed with its multiplication. Then what will happen? It will, when the size becomes excess and it becomes enlarged beyond the capacity of the hepatocytes, it will rupture. So there will be a rupture of schizoids. And thousands of merozoites will be released because this nucleus becomes their own plasmodium stages. They become their own plasmodium stages. So they will release merozoites. So this big plasma membrane with multiple nucleus, it is schizoid, and when ruptured and released different number of plasmodium stages, they are called a merozoite. I hope it is clear. So there will be rupture. When it is ruptured, we will call them merozoites. So these merozoites are the one they will enter into the blood vessel here. They will enter into the blood vessel. Merozoites. They will enter into the blood vessel. So the malaria injects the sporozoite. The sporozoite entered into the liver, changed to liver trophozoites. It will multiply by the nuclear fusions and form a schizoid. And the schizoid later on identify each Plasmodium species into different, and it will release a merozoites by ruptures. But this is a classic life cycles in the liver for what? For like the Plasmodium malariae and Plasmodium falciparum. These Plasmodium vivax and Plasmodium ovale have some unique features. These infected liver trophozoites can stay inside for Plasmodium vivax and for Plasmodium ovale. This liver trophozoite entered into the hepatocytes, and they are changed into other form of the Plasmodium stages called hypnozoites. This is a stagnant form of hypnozoites. It can stay inside the hepatocyte for many years, but when the time comes, they start to multiply themselves and release, and they can cause reinfection. You treat for the Plasmodium vivax, and after sometimes without any Anopheles mosquito or other infections, it can relapse because there is a latent stage here. There is a latent stage, so they can change it into the hypnozoites, and these hypnozoites later on they will change it into schizoid and rupture to merozoite, and they can cause this relapse or reinfection. This is the hepatic stage. This is the hepatic stage of the microorganisms that take places inside the merozoites. So let's start what will happen inside the blood vessels. So this is the hepatic stage. This is the liver. So now once it's secreted into the merozoite, let us see, this is a big blood vessel. Now from the hepatocytes, merozoites are released. So there are merozoites here. Merozoites are here. So these merozoites started to target a special form of cell called red blood cell. They are special, yeah? They are special cells. So they infect into the red blood cells inside the blood vessel. Inside the blood vessel. So let's assume this is red blood cell. Red blood cell. So the merozoites entered into the red blood cells. They will hunt and they will put themselves inside the blood vessels called the merozoite cells, and they form ring form. These merozoites inside the red blood cell, they change it into ring form. Especially in the case of Plasmodium falciparum, it is clearly visible. It is into ring form, and they will change it into what? Young trophozoite. Young trophozoite, and later on they will change it from this to schizoid inside the RBC. They change it into schizoid. Schizoid means these trophozoites start to multiply themselves again. They will form such kind of structures inside the RBC. These schizoids started to happen inside. So these schizoids undergo what? Replications. This nuclear fusions, and they started to release again merozoites here. Again, the same pattern inside the liver. So merozoites are released again. This merozoite what? They infect another RBC. The RBC ruptures and they released. So they infect another RBC. The cycle happens the same. So when the red blood cells, when RBCs are ruptured, they release three important things. One is merozoite. The other one is one is merozoite. The other one is the parasite antigens and hemozoin. Parasite antigens and hemozoites. What are hemozoites? Hemozoites are when the microorganisms inside the RBC, they eat or they use heme as the nutrition, as in their nutrition. So these reddish structures are seen over the GI system of the parasite. So that is called hemozoids. Hemozoids are estimated. So when these merozoites, parasite antigens, and hemozoids are released, the patient started to experience the symptoms. Started to see the symptoms. So like AFI symptoms. As you know, the malaria has AFI symptoms. The malaria has this fever, chills and rigor, arthralgia and myalgia symptoms will start to happen for the patient because during these times for the sake of these parasite antigens and merozoite, there are what? White blood cells. They detect these foreign antigens and they start to release what? Tumor necrosis factor, interleukin 6 and interleukin 1 will be released. So they are responsible for what? The happening of these parasites. And the funny thing is this temperature fluctuations happen in a cyclic way. Later on, we have two type of malaria. We will discuss them in details, but we have quartans and tartans type of malaria. Means they are some of them produce these fevers every 72 hours, and some of them produce these fevers into every 48 hours. We will discuss them in details. So the ruptures, a merozoite released, and this merozoite infect another form of RBC. Again, merozoite ring form young schizoid merozoite. The cycle will happen again. The cycle will happen again. But these microorganisms also, so at this moment, if the Anopheles mosquito bite and take some of the Plasmodium species, there will be no significant changes, or there is no clinically important stages for the or there is no infective stages for the Anopheles mosquito. So here is what happened. Now the ruptured merozoites, they release again these antigens, hemogens, and merozoites, so they reinfect again. But some of the merozoites, merozoites that infect this RBC, some of them changed into another one, and some of them mutated into inside the RBC, they changed into the gametocyte. Gametocytes are the one responsible for the sexual or the diploid, stage of the microorganisms. So gametocyte, it also formed a gametocyte. So these gametocytes they are infective to Anopheles mosquito. So the Anopheles gametocytes are the one that are responsible to infect the Anopheles mosquitoes. So let's say the Anopheles mosquito comes and take some part of the blood. Take some part of the blood. So the gametocyte will enter into the Anopheles mosquito, and it will travel down into the GI system of the Anopheles mosquito. Let's assume this is Anopheles mosquito, this is the leg. So it entered into some part of the Anopheles mosquito. So what happened inside the Anopheles mosquito? So inside the Anopheles mosquito, as I told you before, the microorganisms of mosquito down move to the GI systems. This what you call it the gametocyte. The gametocyte move down to the GI systems, and it will differentiate it into what? Male and female. The females produce the macrogametes, and the male produce a microgamete. Actually, male gametocyte produce 8 macrogametes, and this one is 1 macrogamete. So they do the thing, and they will form it. This is the only stage of this Plasmodium life cycle where there is a diploid stage. Means there are two different unique chromosomes combined together in order to form zygote. The same as for the human, the zygote will be formed. It is only diploid stages, the zygote. So this zygote started elongations and it entered into its surface into the ookinete. There is elongation here. This ookinete penetrates the GI mucosa. This is inside the GI system happens inside the GI system of the mother. It penetrates the GI mucosa and it entered into the cavity, body cavity or malarial cavity. This ookinete changed into oocyte. When it's inside the cavity, it is called oocyte. So these oocytes inside, there is a massive multiplications happen. So there is a massive. So this multiplication. This oocyte is the one that in human merozoites are the one they replicate themselves into and changes. Schizoids are they replicate themselves. But in the case of Anopheles mosquito, the cavity inside the cavity, oocytes are the one responsible to multiplicate themselves, and they release sporozoites. So what will happen? These released sporozoites migrate into the salivary glands. So migrate into salivary glands from the body cavities into the salivary. So this one is infective to human. So again, to remind you here, so these sporozoites released when this malaria infect into another human being, the sporozoite will comes and it will directly goes to the liver, and again the cycle will start. The liver trophozoite, and again. So this is generally the life cycle of the malaria. So as I mentioned before, some malarias are caused this tartans and quartans because the parasites released synchronously. For example, synchronously from this the parasite release synchronously these merozoites. So when these some microorganisms, in the case of merozoite, release every 72 hours, they are also called quartans, and every 48 hours they are called tartans. So what are the quartans and the tartans? So for the quartans it is Plasmodium malaria. The fever gaps, it is usually every other day, but every other 2 days. But in the case of tartan, the fever is every other day. There are Plasmodium vivax, Plasmodium falciparum, and Plasmodium ovale. So this is generally the life cycle of the malaria, how the microorganisms cause disease to human beings. This is how we are getting infected because of this species. Okay, good. So now we have discussed about the microorganisms. So let's see. Mostly you have understand the pathogenesis as well along with the life cycles, but let me give you some pointers in the case of pathogenesis of the microorganisms. So at least we understand why fever is happening. But as I mentioned before, Plasmodium falciparum it is a severe one. Yeah, Plasmodium falciparum is a severe one. Plasmodium falciparum is severe one. So why Plasmodium falciparum is a severe one? Because of the following postulated reasons. The first one is it infects all stages. Infect all stage of RBC. It infects reticulocyte. It infects mature red blood cells. So what does it mean? It infects all stages. It means its parasitemia load is high. So high parasitic load. High parasitic loads. For example, Plasmodium falciparum infect all stages, to make it summarize, and Plasmodium vivax it infect young RBC, and Plasmodium malaria infect old RBC, young RBC. So if you see reticulocytes with a Plasmodium species, it is most likely to be Plasmodium falciparum or Plasmodium vivax. If you see an old RBC and with a Plasmodium species, it is likely to be Plasmodium malaria or Plasmodium falciparum. That is the most important clinical stages. So the parasitemia will be high. Usually it reaches up to 10 up to 30%. Compared to others, it reaches 10 up to 30%. Another most important reasons because the severity for Plasmodium falciparum is it creates cytoadherence. Cytoadherence means the infected RBC attached to the blood vessel walls. So what is the reason why it makes it attached to the blood wall, the blood vessel? Because the microorganisms infected when they infected this RBC, they start to create proteins along the red blood cells. For example, if this one is RBC and if the microorganisms outside them, there forms a membrane. It is called a Plasmodium falciparum erythrocyte membrane. Here is a erythrocyte, there is Plasmodium. So it is a Plasmodium falciparum erythrocyte membrane. So it by creating Plasmodium falciparum erythrocyte membrane protein. It is a protein. So it's a protein that basically adhere to the walls. So infected RBC have these problems. So why the cytoadherence makes it more severe? Because these pathogens, when the red blood cells circulating inside the capillaries, they will start to block microcirculations inside the heart, inside the kidney, inside the brain, inside the lung. So there will be hypoxemia. If there is a hypoxemia, there will be tissue necrosis, tissue ischemia, and later on the patient could have these complications. That is the reason we will discuss about in the topic of severe malaria. For example, for the case of cerebral malaria, the brain capillaries are clogged. For the case of AKI is caused. One reason is because of the cytoadherence. Cytoadherence. So it is most important topic. So the other one is sequestration. Sequestration is also the same for the cytoadherence. Means that this is cytoadherence is attachment to the blood vessel. Attachment is RBC each other. So there will be a formation of sequestration. So like a clot, if they are circulating like a clot. So different RBCs, they are attaching to each other. The RBCs stick to each other. And the last one is there will be a rosette formation. The RBCs attach like this. So the main concept is they alter the microcirculations. There will be a blockage of what we call it microcirculation. Block ይደረጋል. So there will be a damage to the brain, to the damage to AKI, and to the damage to the lung, and again the liver. So these are the just a pathogenesis, how the microorganisms called a severe infection. So what are the clinical manifestations? I have also mentioned here. The first one is they could have fever, they could have chills and rigor, they could have arthralgia. This acute febrile illness symptoms will be worked for here. But for the case of severe malaria, we could have at least additional symptoms. So I would like to mention only the severe ones, because the uncomplicated one is they are clinically it is very difficult to differentiate, because unless the environment is very endemic to malaria, it is very difficult. So for the severe one, so what makes the malaria severe or complicated malaria? The first one is the development of AKI. What is AKI? We will discuss it in the renal nephrology, but if there is a kidney insult, if the creatinine is raised, it will be AKI. The other one is cerebral malaria. In the case of cerebral malaria, there may be altered mentation, or they may be coma, or they may be seizure with the positive Plasmodium species, specifically with the Plasmodium falciparum, and ruling out of other possible causes. If the patient present with these changes, it is diagnosed by exclusion. Before saying cerebral malaria, we need to exclude every positive and possible causes should be excluded. The other one is hypoglycemia. The other one is severe anemia, because we are killing RBCs. Severe anemia. When we transfuse for severe anemia, in the case of Plasmodium species, if the hemoglobin is less than 4, because if the hemoglobin, for example, normal protocol for transfusion is hemoglobin less than 7. But if you transfer with high hemoglobins with a patient tolerating the anemia, the problem is you are giving a lot of RBC. You are exacerbating the replications. But if the patient hemoglobin is less than 4, it is a must to transfuse the patient. The other one is the patient can develop this ARDS, or acute respiratory distress syndrome. The patient could have this jaundice. And finally, in the case of pediatrics, there may be a prostration symptoms, could be another important signs. So how do you diagnose malaria? So diagnosis. The diagnosis of malaria, usually it's very simple. It can be done with a simple laboratory, and we can able to identify the microorganisms from the peripheral field. So the diagnosis, the first one is clinical suspicion. Especially in the case of malaria endemic area, the clinical suspicion must be high. The other one is diagnostic for the malaria is it is blood film. It is a blood film. For the malaria, the blood films, if this one is a glass or the slide, the blood film must contain two things: the thick films and the thin. So we have thick film and thin film. Why we make these two blood films on the same slide? in the thick film, it helps us to identify the Plasmodium because it is concentrated. It is just to detect. This one is to detect the Plasmodiums. But in the case of thin spin, it is to identify the species. Whether it is vivax, falciparum, or malaria, or some other things, because they have some distinct features. I will put examples in the pic by picture here. So it helps us to detect this and identify the problems. The other one is most important. The first one is blood film. Let's say in the case of B, we have RDT, rapid diagnostic tests. In the case of rapid diagnostic tests, we are detecting antigens, specific antigens. It is like picked. There is a strip, we make a drop. If there is test line, there is a control X. If they are both are positive, this positive for malaria. So we are detecting specific antigens. Just to make it brief, what are the specific antigens we usually detect? The first one is HRP2. It is histidine-rich protein. Histidine-rich protein. It is used specifically for what? Plasmodium falciparum. So we can detect for RDT. The other one is if RDT is positive, it is histidine. If and we are using histidine-rich proteins, we are detecting the Plasmodium falciparum. Okay, the other one is PLDH or parasitic lactate dehydrogenase. Parasitic lactate dehydrogenase. It's working for all species. This parasitic lactate dehydrogenase is working for all species. These are the most two common RDT antigens we are using for detection. The other one is we can use also aldolase. It works for all species, but it is commonly it is not applied. So this RDT has its own sensitivity and specificity. So the sensitivity it is sensitivity it is 85 up to 95%, and the specificity it is 90 to 99%. Means once it is positive, the likelihood of being malaria is it is 99%. Usually we are confirming it. So when do we use this RDT? The first one is we use this RDT. It is very useful for remote areas where microscope is difficult and they are not available. It is RDTs. It is one important thing. So RDT positive, it can tell that the presence of microorganism is high, but RDT negative, it doesn't roll out. So the next and the other most important thing about this is species identifications, as I mentioned here. So species identification. So as any healthy individuals, at least able to identify these four major species: the Plasmodium falciparum, vivax, malaria, and ovale via microscope. So how do you identify the species? So let's see about the Plasmodium falciparum. So when you see on the Plasmodium falciparum on the microscope, the first thing you see is there are multiple rings in one RBC. I will put the picture. Multiple rings in one RBC. The other one is they are delicate rings. Delicate rings. So you see this RBC and these are rings like this. These are the rings you see. They are delicate nature. And the gametocytes are the crescentic types or banana shaped. So banana shaped crescentic type of gametocyte. You see this kind of nature, and the size of RBC is normal because it is important. We will discuss it. We will tell you why when I am telling you other species. So the size of RBC is normal. What about for Plasmodium vivax? For the Plasmodium vivax, the size of RBC is enlarged. So there is big RBCs here. The other one is you see amoeba type of trophozoite. There is no the trophozoites. They don't have this specifically shaped. They have the amoeba types of trophozoite. And the other one is you see this Schaffner dots. They are a vesicular things, and usually see on the edge of the Plasmodium, so the red blood cell. So you see these Schaffner dots. The other one is for the Plasmodium malaria to show the classic and the peculiar feature is the trophozoite. It has band shaped trophozoites. malaria ማለት ነው። and the size of RBC is usually normal. The size of RBC is usually normal. And the last one is this Plasmodium ovale. This Plasmodium ovale, they have fimbriated or erect RBC. It is a peculiar thing. Fimbriated means the RBC membrane is like this. They are not like this. They have these structures like rigged type. They are fimbriated type of RBC, or we can say it ridged type of RBC, and the RBC sizes also enlarged and oval shaped. Here it is classical. It is enlarged and oval shaped types of RBC will be the classic symptoms. So we, at least based on these symptoms, we can guess the likely of that microorganisms. So let's come to the final topic, the treatment. So when we are treating malaria, we have two principles. The first one is we have general measures. The second one is we have treating the microorganisms. So first we need to identify whether it is complicated or uncomplicated. So let's start from the uncomplicated. When do we say complicated? Because of the severity symptoms that we are talking, like because of the symptoms. Because of the severity symptoms, we can call it complicated. But when do we say uncomplicated? If they are not absent, but if just the patient present with acute febrile illness symptoms, we are saying uncomplicated malaria. So how do you manage uncomplicated malaria? So you manage uncomplicated malaria based on their species. So for the Plasmodium falciparum, we are usually the artemetrin and lymphadentin combination. It is widely used, artemetrin and lymphadentin. It is also called AL, or it's also called quarter. It is the most widely used. The dose is usually depending on weight and age. I will put the table, I don't know, some part of them on somewhere in the video. But for adults, usually we are giving 4 tablets PO BID for 3 days. We are providing these 4 tablets PO for 3 days. And usually for the Plasmodium falciparum, we are usually providing primaquine stat dose, because these artesunate kills every stage for the Plasmodium falciparum. But the gametocytes usually killed by Plasmodium by the primaquine. So we need to give plus primaquine. At least for adult 50 milligram PO stat is enough to kill the gametocytes. The other one is this Plasmodium vivax. For the Plasmodium vivax, we are usually managed. We have 2 options for the Plasmodium vivax. The first one is we can provide these quartums, but mostly the initial mode of management is it is chloroquine. But in most part of, for example, sub-Saharan nations like Ethiopia, the Plasmodium vivax, it is so resistant. So we need to provide, it is better to provide quartans. But for the chloroquine sensitive environments, we can provide this chloroquine. So it is also again weight dependent. If the size is less than 60 kilogram or kg, we need to provide on day 1, we need to provide 10 milligram per kg. Then after 6 hours, we need to provide 55 milligram per kg. Then on day 2, we need to provide 5 milligram per kg. And on day 3, we need to provide 5 milligram per kg. Completed 3 doses. For adults, this is totally 25 milligram per kg. For adult, we can provide on day 1 1 gram PO. And after 6 hours, we can provide 500 milligram PO. Then on day 2, we can provide 500 milligram PO, and on day 3, 500 milligram PO. This is the general standard management for the Plasmodium vivax. But if you remember, the Plasmodium vivax has one special stage, the hypnozoids. You need to attack this one too, because the chloroquine attach the blood one, the sporozoids, everyone. but it did not attack the hypnozoites, specifically for the Plasmodium vivax and ovale. So from here you need to provide primaquine. This primaquine is a one and special agent, medical agent that can kill the hypnozoites. So primaquine basically can kill two things. The first one is it can kill hypnozoites of the Plasmodium vivax, and it can kill the gametocytes of Plasmodium falciparum. For the gametocytes, we will give them start dose, but for the hypnozoites, we are providing for adult dose 50 milligram PO daily for 2 weeks or 15 days. We need to provide this task. For the pediatric one, 0.25 up to 0.5 milligram PO daily for 14 days must be provided for every patient. But when we are providing primaquines, we need to be more sensitive, because we need to follow the patient at least this RBC serially. If there is a rapid drop of this red blood cells CBC, we need to be suspicious for glucose 6-phosphate dehydrogenase deficiency. We need to be aware of that, because the patient cannot metabolize this primaquine inside, they may undergo this hemolysis. So the final one is malaria prophylaxis, because it is a hot topic, especially caught by WHO in United Nations. So in the case of sub-Sahara and malaria endemic area, it is one of the top 3 fatal, because I've mentioned in different videos. If you see on the amoeba video, the killer trophozoites are, the first one is malaria, followed by the other species, but malaria is the top on the killer. So we need to prevent. How can, because since it is vector-borne disease, its prevention mechanism is very simple. So the first prevention is using of ITA. We need to use bare nets. Bare net must be provided for malaria endemic area. So currently in sub-Saharan nations, usually it is supplemented for free, but everyone must use this ITA. But ITA might not be especially for tourists like who came from the developed country to the sub-Saharan nation. They should basically take, it is better recommended to take malaria prophylaxis. Malaria prophylaxis better to be resistance. In Ethiopia, most of the are resistance for chloroquine. Is a sub-Saharan, they are chloroquine resistant. So what are the recommended agents for malaria resistance? So we need to take malaria prophylaxis agents. So the first and the most recommended one is Malaron. Malaron is a recommended one. It is formed from autovaquines and preguanal. And usually, how do we take this Malaron? We need to take 1 tablet daily. And how do we take that, or how much, or when? So 1 or 2 days before, during, we need to take 1 tabs, and we should have to continue for 7 days after. 7 days after, Malaron should be, it is best for malaria prevention, but the problem is it is very expensive. Yeah, it is very expensive. The other most important and the cheaper one is doxycycline. So how do we take? It is 100 milligrams PO daily. Doxycycline is usually taken as 100 milligrams PO daily, and patients should have takes 1 up to 2 days before the trips, and they should have to continue at least 4 weeks after the trip. So they should have to continue at least for 1 month. And usually this doxycycline is recommended for long stay, but Malaron is recommended for what? Short stay. They are recommended for short stay. This one is the importance is they are cheap and easily available type of microorganisms, but they are contraindicated for what? For pregnant mothers and age less than 8 years. They are not recommended for this type of the populations. Okay, we have Malaron, we have doxycyclines, and the last one is mefloquine is also another choices. Mefloquine. This mefloquine is usually provided as 20 milligrams weekly dose. This one is a weekly doses, and the patient should have to start this 2 up to 3 weeks before early, it needs early initiation. So 2 to 3 weeks before should be started, and it takes weekly, and it is basically recommended for long trips. That is. And the last one is it is Tefnoquins. The fourth one is it is Tefnoquins. This Tefnoquin is usually we are I'm not writing well. Tefnoquin. This Tefnoquin is provided 200 milligrams again weekly, and this should also require initiations for 3 days before the treatments, and they should have to take these Tefnoquins, and after they should have to take at least single dose after 1 week. And again, as the same as Primaquins, this should also require glucose 6-phosphate dehydrogenase test or serially follow up the patients. So these are all possible currently available type of medical prophylaxis for the patients. So just to make it clear, medical prophylaxis, yeah, they are good, they work a lot, but ITN, we need to make combine ITN plus medical prophylaxis is best. So at least whenever patient is traveling to this malaria endemic area, they should have to use this malaria ITN. The last and the most important and fundamental topic is this malaria vaccine. Is there a vaccine for malaria? The question is yes. So what are the currently available types of vaccine? Currently WHO recommended we have 2 types of vaccines. The first type of vaccine is RTS type of vaccines, and it is also called Mosquirix type of vaccines, and usually it is given for places where with moderate and to high malaria endemic area. Moderate to high malaria endemic area. The second one is this R21 called, and it is also called the Matrix M malaria, and it is usually cheaper ones and easily available ones, and usually most common in the sub-Saharan regions. And age of provision is usually it is 5 months. Age of provision is it is usually 5 months. So vaccine basically lower the transmission rate of this malaria, but it does not eliminate it. It does not eliminate it. So still malaria is continued as a major health problems for the sub-Saharan nations, again for all Eastern nations and developing countries. So we need to drain ponds, especially stayed for a long period of time during our summertime. So we need to clear our environmental hygiene, also another important risk factors. So this is all I got for you guys. Have a nice time. Bye.